I'd like to wish everybody a very happy International HPV Awareness Day. On behalf of the International HPV Awareness Day Campaign Committee and the International Papillomavirus Society, IPVS, I'd like to extend a very warm welcome to the panelists on today's webinar and a big thank you to everyone who has joined us worldwide to participate in this webinar. This webinar is actually one of our key campaign events, which I'd like to very briefly introduce. The campaign was introduced by IPVS about 4 years ago with the goal of addressing what we thought was an important gap in efforts to reduce harm from HPV-related cancers, namely talking about HPV itself. There are, of course, many challenges to talking about HPV, but there are some benefits as well. One of them is it's an opportunity to remind everybody that HPV affects everyone, both men and women. It's also an opportunity to tie together various HPV prevention programs ranging from vaccination to screening and treatment. And finally, in the context of the COVID pandemic, it does provide us with an opportunity to leverage heightened public awareness of viruses in general, the importance of vaccination, the importance of herd immunity, and the importance of public health programs. Of course, there are also challenges brought on by the COVID pandemic, and that is going to be one of the topics for today's webinar. Since we are in the COVID pandemic and there is heightened awareness of viruses, we thought it would be a wonderful opportunity to remind people that there are other viruses that have been around for a long time, such as HPV, that can cause cancer, that can kill people, but most importantly, that we already have the tools to beat. So the theme for International HPV Awareness Day, which is March 4th every year, is that HPV affects everyone, but it is a virus that we all can beat, emphasizing the all because it takes work by us together. Today, we send out a variety of social media messages that are designed to stimulate people to obtain further information by going to the IPVS website to look at frequently asked questions and other information, as well as to our more than 100 campaign partner organizations around the world to obtain relevant information in the local context. The focus of today's webinar is to discuss the state of HPV prevention efforts from a global perspective in 2021, particularly in the context of the COVID pandemic, where we will discuss them in general and talk about both the challenges and opportunities raised by the pandemic. Again, I want to thank our panelists and I want to thank our moderator, Rageh Omaar, who will be taking over from me now, and I look forward to a really interesting discussion. Again, thank you for joining us.
Thank you very much indeed, Joel. It's a great honor to be part of this day, and just to reiterate, a very happy International HPV Awareness Day to everyone. And as you were saying, Joel, despite the fact that we're having to meet like this in an age that we're living in, there couldn't be a sort of a better context, I think, for trying to raise more awareness of HPV, as you say, a virus that affects all of us, but in which we have the tools that we all can defeat it. So thank you very much indeed. Let me go straight on to introduce the rest of our panelists. First of all, I'll just, since you handed over to me, say thank you to Dr. Joel Palefsky, who is a senior doctor on infectious diseases and is a specialist. Also joining us, I'm very pleased to say, is Professor Margaret Stanley, who is the president of the International Papillomavirus Society that founded this International HPV Awareness Day. I think over in the United States, we have Satish Gopal, who is a director of the Center for Global Health, the National Cancer Institute. We are very, very privileged to be joined by Dr. Princess Notembi, or Nono Simalele, who is the Assistant Director General for Family, Women, Children and Adolescents at the World Health Organization in Geneva. We also have Peter Baker, who's the Director of Global Action on Men's Health and HPV Vaccination Advocate. And also, finally, but not least, is Patty Murillo Casso, who is the cervical cancer survivor and advocate and founder of a new Carmino.com and member of Women to Women program and the New York Presbyterian Hospital. Welcome to all of you. Let's get straight in because I think this hour is going to go very quickly and we've got a lot to get through on this day. First of all, and I think I'd like to address this to Margaret, Satish and Patty. The premise of this discussion, as Joel was mentioning, is that HPV is a virus that we already know how to beat. As Joel said, we have the tools to beat it. What are then the levers that we have for beating HPV? If I could start off with you, Margaret.
Well, HPV is a very, very common virus, but it causes 5% of all human cancers. Because it's caused by a virus, then vaccination is the obvious route to prevent viral infection. So first on our playbook is vaccination. HPV vaccines are massively effective. We know already from the data they prevent cancer. But second in our playbook is the fact that HPV caused cervical cancer. Cervical cancer, fourth commonest cancer of women in the world. 86% of cases are in the developing world. So we've got a massive equity problem, but we do have the tools to beat it in terms of vaccination. But also we have screening because the cervix is accessible, you can see it, and we can detect the precancers and treat them. So HPV infection is eminently preventable, but you've got to take part in these prevention programs. You have to get front up to be vaccinated. You have to front up to have a screen. The Australians have a phrase for it. You've got to be in it to win it. And coverage, vaccine coverage, and screening participation are the keys to preventing HPV-associated disease. Now, we were doing well in the rich world with vaccination and screening, and not so well with screening in the developing world, but the developing world knows how to immunize, so it was doing not as badly as you might think. And then along came COVID. Yeah. The schools are closed, and there's where we access the vaccine. Women either don't go to screening programs or the screening programs themselves closed down. So COVID's had a big impact. And one of the purposes of this webinar is to remind people that we have these tools, and but they must participate as the programs come back, and to remind policymakers, let's get back to sustainable programs.
Thank you, Margaret. I'm sure we're going to come back to this, elephant in the room, so to speak, of the impact of COVID on the whole wider issue of HPV. But thank you for laying out the clear science that we have in terms of levers. But in terms of advocacy, Satish, I'd like to sort of come to you. What levers do you think we have in that area regarding HPV?
Yeah, so thank you, Rageh. Yeah, of course, I agree with Professor Stanley that the levers of vaccination, screening, and treatment are essential. To me, the additional levers are that there are already good models for how to deliver these components, in community settings. So, probably the best example is HIV treatment, which is a fairly complex undertaking, but, has been successfully provided even to many patients in rural parts of sub-Saharan Africa. So I think the additional levers that I would add is that there actually are good models for community engagement, community-based service delivery, real, models that have worked for how to achieve large-scale, equitable, global public health interventions of the magnitude that we're, I think, talking about on this. So it's not only that the specific tools exist, the kind of models for how best to deliver them, I think, are also exist, and that's important to note.
Thank you very much. Patty, you're a cervical cancer survivor. I was struck by what Margaret was saying earlier about just how large this whole issue regarding HPV and cervical cancer is. Give us your insights as someone who's been through that, has come out and is now a sort of a clear advocate and campaigner on this issue.
Thank you so much. I am a cervical cancer survivor, 11 years in remission. At the age of 48, I was diagnosed in the year 2008. I was 48 and I was diagnosed with stage 2B cervical cancer. At the time, I did not know what HPV was, what the human papilloma was, nor what cervical cancer was. So there comes, and I agree with that, Professor Stanley, that we need to be educated. Needless to say, I got an education real fast, right? Because it was stage 2B, and I was treated with 35 treatments of radiation, 7 treatments of chemotherapy, and 2 of brachytherapy, which is internal radiation. I consider myself one of the lucky ones because even though I went through a difficult journey, I was able to come out on the other side. But we have to remember that there are over 300,000 women worldwide loses their life to cervical cancer. Like Professor Stanley said, most HPV-related cancers are preventable through vaccination and screening. Yet HPV causes over 700,000 cancers worldwide. This is a vaccination that has been out for over a decade. It is safe and efficient, effective, yet it's underused.
Thank you very much indeed, Patty. I'd like to sort of go on to address this issue of why the things that all of you, to begin with, have stated. Why aren't the things happening? I mean, Margaret alluded and touched on the problem of sort of screening, on the problem of the impact that COVID has had in terms of vaccinations between the rich world and the developing world. But what are the key barriers and frustrations that we still face in the fight to eliminate HPV? As we say, the tools are there. What are the barriers there at the moment? And also, just wonder if people could talk about if there's, just touching on COVID again, there is this kind of thing of people not taking up vaccinations. It's a big issue here in the UK related to COVID. Is that an issue as well? If I could start off with you, Princess Notembi.
Thank you very much, Rageh, for that question and also for the points that have been made by the other colleagues and panelists. I think one of the most important challenges that we have considered as one of the things that has made WHO issue the call for elimination is the inequity in access to the tools. You know, a lot of progress has been made in the high-income countries, obviously with very good screening programs. Even when you look now, you know, coverage of HPV vaccination is really quite high. But there's a huge struggle in getting the vaccines into lower income and lower middle income countries. To date, countries that have had access are facilitated by Gavi, the Vaccine Alliance, which has managed to negotiate vaccine prices that are extremely reasonable. Gavi pays just under $5 for a vaccine dose for HPV. And we know that in the high income countries, you know, the manufacturers can sell the same for up to $100, $120. So what we've seen is the doses that are available have moved to the higher income market, and very little has remained for the countries that most need this. So we are really working hard to get more manufacturers on board, and I'm happy to say we've got 2 more manufacturers who have come to submit their dossiers to WHO. And in fact, even with the COVID, when the high-level expert team from WHO went to China recently, a few of the people from the pre-qualification team were able to piggyback on that visit to go and visit the sites where this vaccine is being manufactured And we are hoping, really hoping that the supply constraints will open up. At the same time, Gavi has also engaged in a very robust conversation with how they can support also middle-income countries. It could be tiered pricing or things like that. So some countries have very good experience, like Rwanda reached up to 95, 98% coverage. But there's still work to be done because you've got to have multi-age cohorts, right? Now, when we look at the vaccine supply, we know we've got work to do. And with COVID and the schools, it's a challenge, but it's also an opportunity because, as some of the panelists have said, with vaccines now being central to the conversations around COVID, then we also then can deal with the anti-vax issues, the hesitancy that we've seen amongst parents and others, who are the caretakers of these young girls and boys. So we are looking at those things. And then the barriers, obviously, to screening are huge with health systems issues, with myths, and many things that have stopped women from coming into the system. So there's a lot of work to be done.
Indeed, a lot of work. Thank you very much indeed, Dr. Princess Nono. If I could turn to you, Joel, and also Peter. Inequity of access, as Nono was saying there. We've also got a question which is important to get across, and it's from the Q&A, which says, will a single dose of the HPV vaccine confer adequate protection? So Joel, if I could throw those two things to you, what Nono was saying and that question, and then bring Peter in.
Sure. Well, maybe I'll start with the second question first, which is about one dose. There's some very encouraging data on that. But there are clinical trials that are currently in progress to compare one dose to 2 doses. And we'll need to wait to see what the outcome of those studies is before we can recommend one dose. If in fact some of the early data are borne out, I think that would be potentially a huge game changer for the vaccination programs. But we need to wait a little bit longer, I think, before we can come down on that. As far as some of the other barriers are concerned, one that vaccine hesitancy and misinformation are enormous, as Dr. Princess Nono said. But there are other issues too. HPV is a sexually transmitted virus, and there's a lot of stigma talking around sex. In fact, stigma is a major issue all around. The body parts that HPV infects are stigmatized in and of themselves, and we don't like to talk about them publicly. HPV also has a disproportionate effect on stigmatized populations, people with poorer access to healthcare, lower socioeconomic status, HIV. These are all also issues that raise challenges. And then there's men, because men are a very important part of this equation. From the point of view of transmission and acquisition, but also cancers. Men do get HPV-related cancers. Unlike for women, for cervical cancer, for which there is screening, there are no screening programs yet for cancers in men, and that is a barrier to being more proactive about preventing those cancers, except for vaccination, which is the one tool that we still have. And we're a little bit behind in getting boys vaccinated, though getting a little bit better. The focus does need to be on young women while we still have implementation issues. But vaccination of boys is very important, and we hope to get to gender-neutral vaccination.
Thank you very much. Well, that's a perfect segue to bring in Peter on this, on the question of vaccinating boys and the role of men in all of this. Peter, you're a director of Global Action on Men's Health and, of course, HPV vaccine advocate. I'll go ahead.
Well, I think Joel's identified the issue very clearly. I think we still tend to see HPV and cancer as a women's issue. And it is, of course, an issue for everybody. HPV affects everybody. Everybody can catch it. Everybody can transmit it. And men aren't adequately protected by girls-only vaccination programs. Obviously, a man can't catch HPV off a woman who has been vaccinated. But even in the countries which vaccinate very high proportions of women, like the UK and perhaps some other countries in Europe and Australia, Nevertheless, still at least 10 to 15% of women aren't vaccinated. And so men are still vulnerable to infections from those women. Also, of course, men who have sex with men are completely unprotected by a vaccination program just for girls. And we know that men who have sex with men are particularly vulnerable to anal cancer caused by HPV. So there's a very large problem with men, and we need to vaccinate both sexes. And we need to think about all the cancers that HPV causes. And of course, HPV doesn't just cause cancer. It also causes genital warts in very large numbers. And genital warts won't kill you, but nevertheless, they can be psychologically very difficult to live with, and they're difficult to treat and expensive to treat. So we have to think about all the diseases that HPV causes, and there are some others as well.
Thank you very much, Peter. There's questions coming in. I'd just like to tell everyone who's participating in this to do raise your questions at the bottom of the screen. You'll see a Q&A section. I'll try and get them in. We've got a lot to get through. The one question that's come through, I think is really, really important, is to address the whole issue of vaccine hesitancy, which is so, very, very much, relevant with regard to sort of COVID, as I was addressing earlier. Perhaps if I could put that back to you, Margaret, is vaccine hesitancy when it comes to HPV an issue as well there?
Absolutely. Absolutely. In fact, vaccine hesitancy and anti-vaccine sentiment is one of the major barriers to vaccine uptake around the world. Now, in my opinion, my personal opinion, a key group to educate and constantly reinforce are healthcare professionals. The people who give you the vaccine, the nurses who do the screening tests, and the doctors who do the treatment of the precancers, because they need to be convinced, first of all, of the effectiveness of the vaccine and the safety of the vaccine. These vaccines are incredibly safe. They've been out there now for 20 years. And we have no signal that there's any adverse event of serious nature attached to these vaccines. And then we have to really transfer that to the population. There are different reasons in different cultures why people are worried about vaccines. But I tell you, vaccine hesitancy is quite a major problem for HPV. And social media poisons the view and transfers. This is gossip on a global scale. Somebody writes something ridiculous on Twitter, and in 5 seconds later, it's everywhere around the world. Now, we as healthcare professionals have to counter that, and we have to put some passion into it. But it's a major problem.
Thank you very much indeed, Margaret. We've got some comments rather than sort of questions coming in, which I think are very relevant. I'll just read them out. In Latin America, there was a vaccination program with 4 to 6 year olds. Why not integrate at an earlier age a one-dose boys and girls if these vaccines are proven safe? And then someone from Argentina, sorry, this is scrolling up very quickly. I am a coloproctologist from Argentina, and gynecologists here do not usually refer their patients who have had HPV-related cancer in the genital tract for prevention. Let's bring the discussion back round to, of course, everything is overshadowed by COVID-19 this past year, everything in every country. And the pandemic, as you were referring to, Margaret, earlier, has changed how we all not only live day to day, but address our health in the wider sort of context. And this has important implications for HPV. I'd like to start off by asking, first of all, what are the challenges that COVID has presented in the fight against HPV? If I could start off with you, Patty.
Unfortunately, due to COVID, cancer screening have plummeted. In the United States alone, cervical cancer screening has gone down 94%. We all know that cancer screening saves lives. I just had my cervical cancer screening this January. I felt safe. Doctors in doctors' offices are doing a tremendous amount of precautions to make the patient safe, comfortable, and secure. So we need to remember that prevention and early detection save lives.
Thank you very much indeed, Patty. If I could ask you, Satish, to comment as well. I mean, what are the challenges of COVID with regard to HPV, do you think?
Yeah, thank you. So just building on what Patty said, I think, as health systems have had to prioritize service delivery, I think one of the things that has clearly suffered is services that are directed at healthy asymptomatic people, which is the domain where much of what we're talking about today sits. And again, I think in the United States, there's been some recovery, but still not back to pre-pandemic levels. And that has created a huge backlog, of course, from nearly a year of interrupted routine healthcare service delivery that we'll have to figure out how to accommodate. In some ways, I think that this problem has been even worse in low and middle income countries where, as Professor Stanley alluded to at the beginning, much of the burden exists. These are healthcare systems that are often under-resourced with respect to personnel and infrastructure, even at baseline, even under the best of circumstances. And so, as they've had to deal with COVID, I think inevitably, their available resources have largely been redirected to dealing with, the kind of urgent public health threat that COVID has presented. So I think certainly the situation that we have seen in the United States, if anything, has been magnified in LMICs. The other final comment I would make here is I think COVID, because there's been so much attention to the rollout and the development of these vaccines, it has, I think, had an accelerating effect on vaccine hesitancy, vaccine myths and disinformation. There's so much more out there, and I think there may be spillover effects that we have to be really cognizant of to other, again, much more the HPV vaccine, older vaccines that have a much longer track record may suffer from some of the concerns that have been raised with respect to COVID.
Margaret, you wanted to say something?
Yes, I think there are several levels about this. There's first of all the immediacy of the anti-vax sentiment and the wideness of the distribution of false information. But secondly, we have to start doing really serious research on why people are so influenced when there's clearly death from an infection going around, and there's something that will prevent that, but they don't take up the prevention. So we say we need to educate, we say we need to inform, and that is true, but we really need to start understanding why people will not take up a health prevention, which is going to save their lives. And they won't. So that to me is, once I know that, I'll be able to design strategies to overcome it. But I've got to know why people are doing this.
That's a very good question. And of course, affects not just HPV, but so many other sort of illnesses, conditions. And COVID has really brought that to light in every sort of country.
I would also like to say that COVID has given me terrific opportunities because I'm a basic immunologist and I need to explain to people why vaccines work. Before, I used to have a big job because they didn't know what an antibody was or a virus was or why you put needles into the arm. That is widely understood now. So COVID's had a slight silver lining.
Okay. Dr. Princess Nono, if I could ask you, from your World Health Organization perspective, the impact that COVID has had with regard to HPV in the sort of developing world. And there's a very interesting question also from someone called Osman who says, hi, how can a developing country get access to Gavi program? I'm a UK gynecologist, but originally from Sudan, and we are the Society of Sudanese Gynecologists and are keen on introducing HPV vaccines to the country.
Thank you very much. I think the question of the impact of COVID, it's something that we've measured and we've seen a drastic impact on services in almost all countries of the world. And most importantly, in high rates of just no services being given in low income countries. So this has been quite devastating, not just for cervical cancer or cancers generally, but for non-communicable diseases, for communicable diseases. We've seen HIV clinics not providing medication. So it's been a disaster, I think. So as we promote this restarting of essential services, rebuilding, we've worked so hard with member states as WHO to provide the guidance, to show how they could, triage patients, how they could maybe, look at how they lay out their services so that we've got the non-COVID care going on as you deal with the COVID patients. So it's been very, very difficult, but slowly we see services restarting and countries starting to think, because there's a lot of information out there that's showing that the benefits of continuing essential services far outweigh sometimes the suspension in a way. Nothing compares to COVID because it's immediate, it's difficult, and people have been dying in large numbers. But we've argued that, women continue to die even as other people are dying of COVID. So we've got to balance our advocacy message. And that's what we've been trying to say. There was also a question, Rageh, if I can quickly go into that question about Sudan and how they could access Gavi supported vaccines. I think Sudan is on the list of countries that are eligible for Gavi support. I think we've had a stop and start there because of the humanitarian situation that persists there. But from a GNI perspective, Sudan does benefit or is eligible. And I would advise the person who's asking the question to go on the Gavi website and find out more how they can enroll into the Gavi program.
Thank you.
With the strategy, just the last point on the cost-benefit analysis, many of the countries have been wanting to do small components of the continuum of care. A lot have said, okay, we will focus on the vaccines because we've got them. Others have said, why don't we just not do the vaccines? But the strategy we have encourages countries to do all three. That is, vaccinate, screen and treat cancer lesions, and treat women who've got advanced cancer. Because putting all of that together is so cost beneficial. The return on investment is in the strategy. We show that for every dollar you invest in doing this, the return is about $26. So we know about the prices. As the pipeline improves, we know there will be a downward drive on the prices of the vaccines because of the economies of scale. And we are encouraging countries to continue to prepare for the introduction of HPV vaccines. And with the current technology for screen and treat, which Margaret and others on this panel know about, we can get to a single visit screen and treat for women who are eligible. So that's the work we do in WHO, and we believe that all three are very important. Thank you.
Thank you very much, Dr. Princess Nono. I'd like to bring in Peter and also Joel, if possible, picking up on this whole question of COVID, and Margaret alluded to it earlier. Is there opportunities in this crisis with regard to moving forward the awareness and battle against HPV? What, has COVID kicked up some things that could provide an opportunity? And there's a question here which I think is sort of relevant. They said from a campaign or advocacy point of view, as with COVID, is there a way of sort of addressing HPV as a virus that's out there in plain sight that we also need to tackle in the way that COVID is? Maybe I could start off with you, Peter, then followed by Joel.
Yes, thank you. I mean, I think there are some silver linings in the COVID cloud, as it were. I think there are some positive things we can point to. I think, first of all, COVID has shown us just how vulnerable we are as a population to infectious diseases, where there are no vaccinations. I think we've become complacent, particularly in the richer countries, about infectious diseases. And I think that's reinforced vaccine hesitancy. People sometimes don't see the point of vaccination because we don't see these diseases around anymore. Diphtheria and so on, we're not aware of them because of the success of vaccination programs. But I think what COVID may have woken us up to the importance of vaccination to protect us against infectious diseases. And that could obviously help the case for HPV as well. I think also the pandemic has reinforced awareness of the need for prevention and public health. Public health tends to be under-resourced. We tend to put most of our health resources into acute medicine, treating people who are already sick. But I think what we've realized now is we have to stop people getting sick in the first place through prevention strategies. And again, that's where vaccination and screening play a crucial role. I think the third area where COVID may have caused some kind of rethink for many of us is in the area of health inequalities. And we've seen that COVID has had a particularly devastating impact on people who have low incomes, from some ethnic minorities, people with disabilities, and other groups. And again, they're the groups who are most affected by HPV and HPV-caused cancers. So again, I think that this greater awareness of health inequalities and hopefully a desire to tackle these inequalities will also help us in the struggle against HPV-related diseases. And I think also, speaking at the kind of general level, I think the success of the COVID vaccination program, and we do expect it to have a huge impact, will hopefully restore a faith in science and a confidence that vaccinations are safe and can actually protect us in a very real and effective way. And the final point I make, and this is much more practical, is that we're going to see over the next few years, it's already started in some countries, the build-up of a huge vaccination infrastructure, vaccination delivery systems on a vast scale. And once we start to get on top of COVID, we can hopefully use those structures, those systems, to deliver other vaccination programs, including HPV. So I think there are several reasons why we can be optimistic in the kind of medium and long term about vaccinations in general and about HPV in particular.
Peter, thank you. Joel, I'd like to bring you in on this sort of issue of, possible silver linings in the COVID cloud regarding HPV, and particularly that last point that Peter put about this huge global, vaccination infrastructure, providing a basis or a sort of a system whereby, other issues like HPV could be addressed.
Yeah, I think Peter said it very well. And actually, I like the analogy that Satish drew with HIV. Here is actually an example of where infrastructure set up to take care of one viral problem was used to some degree to help with another viral problem. So the PEPFAR programs, for example, in some countries in sub-Saharan Africa were used to augment screening for HPV-related diseases, first in women living with HIV, but were then expanded to women who didn't have HIV. And I think the entire population in some of those places benefited from that infrastructure. So this has been done before. One more negative element of COVID that I just want to emphasize is while it is absolutely a short-term priority to get us back to where we were in terms of the implementation of HPV prevention programs prior to the onset of the pandemic, our campaign, of course, has been going for years, and HPV has been around for a very long time. And my concern is that the resources that have been diverted appropriately to the COVID pandemic might prevent us from expanding. We really need to go beyond restoration of where we are to massive expansion of these prevention programs to achieve the full potential of the WHO elimination program. So I'm hoping that that doesn't get derailed by economics.
Okay, the very good question here from Sarah Jerving, who is a journalist at DEBEX. And I might start off with you, Patty, and then open it up to others. Could you please talk about how school closures from COVID-19 might have impacted school vaccination campaign? Will it be easy to catch up when the girls that were missed during this time frame. Are you worried about that, Patty? I mean, the school closures having an impact on girls that might have been sort of vaccinated?
Absolutely. It's you know, I have done presentations in school, and I have targeted Parents and Teachers Association to educate them on the vaccination, and it hasn't been possible to get there and open the vaccination discussion. Also, a lot of parents are not taking their children to their pediatricians due to COVID. So that makes a big difference in the vaccination also.
Margaret, do you want to jump in there? This question about school closures because of COVID and girls missing out on this vaccination?
Well, the UK has tackled this in a very sensible way. As the JCVI has issued recommendations which are really appropriate under the circumstances. So we know that because the schools closed in 2020, there are cohorts in the January term and cohorts in the Easter term who didn't get there as a first or second vaccination. That's 2020. In 2021, the direction from the JCVI was that the cohorts who hadn't been vaccinated in 2020 were given one dose, and every effort was made to catch up by giving students who'd missed out one dose and delaying the second dose till we got the populations back at least with some immunity. And that's a very intelligent strategy, because the evidence is becoming stronger and stronger that one dose actually works. So these kids are protected. Now, the problem comes if you don't have a school program, because there you've got to take your child to a clinic or individual physicians. And that COVID fear then dominates. And that's been one of the reasons why women haven't gone for screening, because they're frightened, and why parents won't take their kids to clinics and to their practitioner, because they're frightened of the infection. And so there's a fear of getting infected. That will be overcome to some extent when we're all properly vaccinated. But it depends a lot on your social organization and your medical infrastructure and how strong it is. The UK is good because it's got a centralized direction, and it's always immunized very well. Most other countries in Northern Europe will do well. The real problem is if you're trying to do this in countries where the resources are massively stretched and the medical infrastructure is fragile, as Princess Nono referred, then that's going to be difficult to be brought back. So school closures have had an impact on the vaccination program, but it can be recovered, providing the organizations there. And that's one of the things that we have to keep pushing. Yeah. Get yourselves organized, get back to it.
Okay, thank you, Margaret. I'd like to move on because one of the other things that COVID has thrown up is this whole issue, I think, of adapting how healthcare systems are having to work, and increasingly turning to this kind of method. I mean, you know, when I want to sort of visit my local, you know, doctor about something, I have to do it virtually, and telehealth is becoming a major issue in a way that it perhaps wasn't so much before COVID. Do you think this is of relevance to the fight against HPV? Maybe I could turn to you, Satish, on this to start with.
Thanks, Rageh. Yeah, I do think it's of relevance. You know, cell phones, for example, are amazing tools that are quite ubiquitous now. And as you've mentioned, we've seen even with COVID, the deployment of these novel apps that have really allowed, you know, contact tracing, linkage to testing, delivery of results back to patients in a way that has really enabled, I think, public health control, which you could imagine being used similarly for HPV. Dr. Princess Nono also already alluded to these three separate pillars that we've been talking about throughout this session of vaccination, screening, and treatment, and the need to link those three effectively together. Again, you could imagine telehealth, mobile health, and other solutions being used as tools for creating these linkages. I do think it's important to emphasize that these tools are not the kind of magical solutions that I think is often claimed. I think they often need to be tested and validated in specific contexts, with attention to the humans who will be using them, and ultimately, have to modify their behavior based on information that they're receiving using these tools. So for example, telehealth is not going to be a substitute for having adequate vaccine supply, but it could be used as a tool for matching available doses to eligible recipients. So that's just one example.
Okay, thanks, Satish. Dr. Princess Nono, of course, I've just 2 weeks ago was in East Africa and in sort of, Ethiopia and in Somalia. And of course, they're very, very fragile and stressed infrastructures. But, phones and mobile phones and, smartphones are ubiquitous even there. Is this at all relevant, do you think, this whole issue of telehealth, or is it, as Satish was saying, just no substitutes in environments like that for real sort of delivery?
There are opportunities, I think, for telehealth and for the use of mobile phones to get women back. There are countries that are piloting these, and they're finding that some are doing well in getting women back, others not so fantastic in getting women back. But I think that is one of the biggest bottlenecks in terms of what are the challenges that you raised earlier. Women not coming back to get the result, and to then be further treated. So we've been really thinking hard about what are the ways in which we can get women to come back. And in one of the countries that's doing very, very well, in Zambia, there are huge networks of cervical cancer survivors. They formed a whole group about, I think it's 120,000 odd women who are just a big group that just continues to advocate, but it's also a safe space for other women who are newly diagnosed with cervical cancer to come and join, be supported. They're called the Teal Sisters, and they are such a good example, which is now spreading across East Africa, of these networks, which are so familiar with the barriers in communities. And we're also starting to work with NGOs that are primarily driven by men, led by men, to start seeing how we bring men in as partners in this whole issue of not just cervical cancer, all HPV-related cancers. And then you have a conversation that brings the young girls and the young boys into the space that can then improve. So whilst waiting for the vaccines and all these things, these advocacy movements are starting to demystify all of these things around those parts of the body that are generally taboo in many of these communities. So there is room, because as you said, cell phone penetration in Africa is really high, and there are very smart innovators from the continent who are helping us to see how we can reach women with information around cervical cancer and other diseases as well. So much hope here.
Thank you very much. A very good question just come in. What strategies can be put in place to understand why populations are hesitant to take up the life-saving HPV vaccines? Could I point that in your direction, Joel?
Well, I think we've covered some of these topics already. There's a lot of misinformation, for example, about vaccines and vaccine hesitancy for a variety of inappropriate reasons. The lack of full utilization of the tools that we have available to us really is a multifactorial issue. It's that misinformation, but it's also, of course, lack of infrastructure. There are probably many people who want to take advantage of these programs or would if they were available. And so we need to also think about how resources can be appropriately dispersed by public health authorities, particularly in low and middle income countries where the rates of cancer are highest. to make them more available. So it's a combination of resource allocation, education, and one other issue that I think bears emphasis is that the communication needs to be culturally appropriate. Yeah. The message is not going to be the same everywhere, and it's not going to be the same according to age, socioeconomic status, geographic location. We have to tailor the message.
That's very good point. Communication has to be culturally appropriate. I've got another question here. Should we pay, it's more sort of scientific, if I could put it that way. Should we pay attention to the prevalence of the different HPV genotypes in the different regions and to analyze the changes after the start of vaccination to develop better strategies? Briefly, if I could just stick with you, Joel, and then I'll open it up.
We were always looking at that, but I will say right now the evidence is very clear that the currently available non-valent vaccine covers more than 90%, probably closer to 95% of all cervical cancers all over the world. So while there may be some variations from genotype to genotype, for the most part, the currently available vaccines are very, very capable. The issue that the questioner brought up is what we call replacement, where the concern early on in the vaccine era was, well, we're going to get rid of HPV-16, but is some other nasty virus going to take its place? And thus far, we've not seen any evidence of that. Perhaps Margaret would like to add to that.
Yeah. The bottom line is that wherever you are on the planet, HPV-16 causes pretty well 60% of all cervix cancers and about 90%, I'd say, of anal cancers, and the same for vaginal and vulval and probably oral. So it doesn't matter where you are. The HPV that's causing your cancer is actually covered by one of the available vaccines, particularly the non-valent vaccine, which covers 7 cancer types, and particularly HPV-16 and 18, which together cause 70% of cancers, and the other HPV cancer types in the non-valent vaccine bring the coverage up to 90% of all cervix cancer cases and pretty well 100% of anal and oral. So the vaccines work, and the evidence from studies worldwide from WHO, from the regulatory bodies around the world, is that the virus prevalence, that is the amount of virus in circulation for the vaccine types, declines with vaccination, and the other types stay pretty well stable. And there is no mutation in these HPV types, and there is no vaccine-resistant HPV types. So in other words, it's they're pretty good vaccines.
Good. Thank you very much indeed, Margaret. We're down, I can't believe it, to the last few minutes, 7 minutes. So I really want to sort of pull back now on this HPV, International HPV Awareness Day, and ask everyone on the panel what you all think are the most important actions that we can all take to help beat HPV for good. A lot of sort of different issues were raised, talk about the kind of opportunities that COVID stresses. And I suppose one of the things that's important to me personally is not just the sort of educating and the health professionals, but also educating parents as well around the world. So if I could start off with you, Dr. Princess Nono first, what are the most important things you feel we need to do to tackle HPV for good?
Two things I think stand out for me, and it's almost like a bottom-up and a top-down type approach. I think we don't speak enough about HPV and its relationship with cervical cancer to politicians and to policymakers. I cannot tell you how many times when we present the strategy, when we talk about cervical cancer, that there are very few politicians who link the two. When we start talking about cancer, they see the big cost, as it were. But just recently, I was just talking to one head of state, and he was saying, "Oh, but are you saying there's a vaccine that can really stop this cancer?" I said, "Yes." And he said, "Oh, but it's the same as COVID. So why aren't we doing it?" So I think we need to keep pushing, simplify this message, especially in countries that also have an HIV burden, because then people get confused. I talk about HPV or HIV. So top of my list would be educate the politicians, educate the health providers, but more importantly, educate women. And for several reasons, so that women, once they know that this is the situation, this is what's causing my problem, they can start to be advocates and demand the services from their governments. Because right now, there's nothing bringing these two together. And women's groups must start to advocate holistically. Because once you speak about breast cancer, right, everybody knows, and there is a community around that. But I think if we brought these two issues together, because cervical cancer, breast cancer, top of the list, even in developing countries, bring those communities together, we would have more advocacy that's more stronger. And then the last point is to advocate for access to these tools at prices that are reasonable and affordable for the countries that have the highest burden. We've got to really keep pushing the manufacturing industry to consider, the costs of these vaccines because they are such a huge and genuine investment in stopping cervical cancer.
Okay, if I could bring in Peter and then Satish after that.
I think for me, from my perspective, I'd say don't forget the boys. HPV affects everyone and everyone needs to be protected. And also, if I can pick up Dr. Princess Nano's last point, we need to advocate around this. A lot of these programs won't be introduced without a struggle. And I speak from some personal experience here of having been involved in a campaign in the United Kingdom for 5 years to get the vaccination program extended to boys. It took a lot of hard work to persuade the government to do what was to struck most people as being blindingly obvious, that it made sense to vaccinate both sexes. So it took a long time to basically persuade them to take that step. And I suspect the same will be true in many other countries. So we need to make sure that we get the vaccination programs that we deserve, and we need to work together as organizations and as citizens to try and make that happen.
Okay, Satish, we'll try and make it as quick as possible. We've got a few minutes.
Sure. I think the most important action is to make a real commitment to health equity with the emphasis on real.
Thank you very much indeed. Patty, to you as an advocate and a survivor of cervical cancer, what do you think is the key things that need to be done?
Two things. As a patient, I like the education because we have to take the stigma out of the human papillomavirus, the HPV. Stigma that leads to misinformation for women and everybody else. And the other thing is vaccination to protect the next generation of HPV-related cancer and ultimately eliminate these cancers.
Thank you very much. Margaret, over to you.
I think it's educate, educate, educate. Keep saying HPV causes cancers. HPV vaccines prevent infection, prevent the cancers. They're safe and they work.
Thank you very much. I'm just going to hand over to Joel, who for a last comment and also to bring the session to an end. But some of the things I've sort of, key takeaways, that I've heard, simplify the message, educate policymakers, women and health workers, make the message culturally relevant, involve boys and men, spread the message that we all are vulnerable and we're all affected and that we have the means and tools to beat it, and make access far and wide. Final word to you, Joel.
Thank you so much, Rageh. The only other thing I would add to the many comments, which I agree with all of them, is that it behooves us all to destigmatize HPV. This is a problem, as you said, that affects everyone, and together we can beat it. So I think this is a lovely end to what I thought was a wonderful discussion. I want to thank you, Rageh, for your very capable moderation, and to the wonderful panelists who brought their expertise to us today. I want to wish everybody again a happy International HPV Awareness Day. Please, we hope that you'll participate in it, spread the word, pass on the messages, send your constituents to the websites of your local partners and to the IPVS website. The website is askabouthpv.org, and all the information about the campaign is there. So please participate. This will be a year-round activity, and we look forward to working with everybody. Thanks to all of the people who've been participating in this webinar for joining us, and we look forward to working with you in the coming year.
Thank you very much indeed. Stay safe, everyone. Goodbye.